Hi, I'm Sarah Miller. This is my newborn I'm going to be assessing. Also, just a quick PSA, my stethoscope broke, so I am just going to be acting out, auscultating and everything, but it will be obvious. So, upon entering the room of the infant, we want to just assess what is happening overall, if they are sleeping, if they are awake but looking around, if they are breastfeeding in an active alert state, or if they're crying. We also want to notice if they seem like they're in any pain or in any distress whatsoever. Obviously, with infants, they cannot tell you if they're in pain, so that might be a little bit difficult, but our infant right here is just happy, awake. Pain is probably a 0. So then starting with unswaddling the baby, we will first auscultate the heart tones for 1 full minute, noting if there is S1, S2 present, if S3 and S4 are also present, or any other adventitious sounds. And then the heart rate should be between 130 to 160. So then moving down, we would assess the lungs, listening bilaterally in all 6 spots, front and back, for any adventitious sounds, wheezing, crackles, anything like that. And also at this time we would take the respiratory rate. This should be between 30 and 60. And before we move on, we want to auscultate the bowel tones as well. Just before we do any other assessments, just get all the listening out of the way, so that way baby can stay happy for most of the assessment. So then listening to the bowel tones in all 4 quadrants. And then we are literally just going to go head to toe. So observing baby unswallowed, we want to look at their skin, if they are heavily jaundiced, if there's any rashes, birthmarks, pallor, things like that are deviations from just the normal skin tone for the baby's ethnicity. So then we want to start at the head, look at the anterior fontanelle. We can, Brinkley's coming through here. But we'll assess the corneal suture, which goes across the head, as well as the sagittal suture that kind of goes like a mohawk down baby's head. But this anterior fontanelle, or the soft spot, is what we're going to be looking for. We also want to notice the shape of the head. Literally a cone head is what they call it, but if there's any swelling or edema on the baby's face from a traumatic birth or just coming through the birth canal, those are all things to be aware of that can be natural. Moving on down, we want to assess the eyes. We ultimately want to look for the red reflex for cataracts, but at this time we're probably just going to be looking at the eyes for reaction in the pupils and perla. So the easiest way to do this is just to turn the lights off and then shine the light. We never want to pull up on baby's eyelids. That's a no-no. So then onto the ears, we want to make sure that both are present, if they are actually not just holes, or if the actual whole ear is present as well, and that they're symmetrical and level with the eyes. So moving on to the nose, we will occlude each nostril and check for patency. And if baby has like a stuffy nose or something is occluded, we can use that bulb suction tool that should be in every single bassinet and just kind of suction it out, put it on a tissue, and do that with the other one and see if that helps. Next, we want to check the mouth. So cleft palate cannot be noticeable from the outside, so we do want to reach in and just kind of feel that soft palate, make sure that there's no gaps or anything. So then we will feel for it, see if there's any neonatal teeth, which is just the gums. And then we can also assess for the sucking reflex at this time just by putting our finger in the baby's mouth. They should just naturally latch on and want to suck on it, so that's normal things to look for. We should also at this time just brush the baby's cheeks, and they should turn their head side to side. We also want to make sure we assess the neck, that the trachea is midline, if there's any deviations in that. Moving on down to the chest, we should see that xiphoid process. We do at this time want to notice if there's any respiratory distress. Obviously, we would probably see that after auscultating, but unswaddled and everything, just making sure we are noting that. And then also that symmetry of the chest movement with the rise and fall of the chest. Onto the arms, making sure that they are equal in length. We do want to physically count each and every finger and make sure there are 10 fingers and 10 toes. Assess for capillary refill. That should be less than 3 seconds to show us that there is adequate perfusion. And then still moving on down, we do want to look at the legs, make sure the legs are equal, and then as well as again count 10 toes. And then going back a little bit to the hands to check for the plantar reflex, where we literally just put our finger right in the baby's hand, they should grasp on. And then for the toes, the plantar reflex, I think I said I hope I said palmar reflex before, but yes, the plantar reflex on the feet, and then those toes will just curl around, as well as the Babinski reflex, where we just stroke the infant's toes spread out, and this goes away at 6 months. So before 6 months and before, totally normal. After is when we may have some neurological changes. And I don't know if I said this when assessing the respiratory rate, but it's 30 to 60, which just popped into my head. So that's on there. Moving along, we are going to assess the GI and GU area. We want to look at the abdomen for any distension, anything along those lines. And then we also want to look for if the baby's vomiting, like what color that is or what's happening there. Those are just things to be thinking about. That could be some abdominal issues, but distension, the main one. So then between male and female, females will have a labia minora and a labia majora. The clitoris should be hooded still. And in the folds of the vagina, there might be white discharge called smegma. Normal, just something to be aware of and be cleaned. A female newborn may also have a pseudo period, and this is just because mother's hormones are still circulating through her, and totally normal, just something to make sure the parents are aware of. In a newborn male, we will assess the penis, assessing if the meatus is where it's supposed to be, if it's somewhere else, whether dorsally or anterior, like on the front or the back. Those are issues and do require surgery, so just being sure of that. It is up to the parents if they want their child to be circumcised or not, and in the instances of not, making sure the parents know to pull back that foreskin and clean the penis so that way we can prevent infection from occurring. To assess the newborn on their testicles, to make sure they have descended, we just feel them, 2 fingers. They should feel like 2 little marbles, and that is that. And after assessing the GU on the baby, we do want to wait for that first stool, which is the meconium. It's usually a greenish, blackish, sticky sort of substance, as well as the first urine, which could be like a dark amber color, just because babies do produce a lot of that hemolysis is occurring in a baby, especially through delivery. So that all that coming through the urine, totally normal. Just something so that parents aren't freaking out, especially with new parents. So then when we wrap baby up again, we do want to fold down the diaper, so that way it's not interfering with that umbilicus that is probably still attached, the umbilical cord. That's also something to educate parents on at this time, just to make sure that they know, hey, in a couple days it's going to turn black and fall off, and that you don't need to be worried about it. Here's signs of infection and everything like that. So then moving on, actually before we do that, we do want to look at the baby's hips. So what we're going to do is for hip dysplasia, we're going to reach up and kind of push on them, and if they pop, baby does have hip dysplasia. If they don't move or anything, baby is good to go. Before we turn baby over, we can also test for the Moro reflex, where we just pick them up kind of, and it should kind of just startle them. So they should pull their arms out in and should start crying in a normal reflex for the Moro reflex. Moving on, flipping baby over on their back, checking for the curvature of the spine. We do want to check for spina bifida, and then making sure that if there's any scoliosis, curvature of the spine. This is also where we will find our Mongolian spot. Another teaching point for parents, which this all can be just a teaching point, the Mongolian spot is just an excess of melanin. Also nothing to be worried about. It could probably just go away, totally fine, totally normal. Sometimes there is a sacral dimple. This sometimes does indicate spinal injuries, I think. I can't think of the word for it right now, but it might be a cause for concern, just something to document and monitor. And then we are going to flip baby back over. We're going to wrap them up, swallow them up, give them back to mom. But before we do that, we're going to take the baby's temperature, which is higher than normal. It should be about in that 99 to 100 degree mark. In the auxiliary, so in the armpit, making sure you pull baby's arm over. And then we're going to finish swallowing them up because they're probably very upset at this point, and we're just going to give them on back to mom for them to calm down. And yeah, and then document like we do with everything. Thank you.